Good morning, and thank you very much for the invitation to speak today. It is a pleasure to be here and to share some of our clinical experience from the ENT department at Clínica Barajas in the Canary Islands, Spain. In this presentation, I will talk about the diagnostic value of wideband acoustic emittance in middle ear pathology, and I will illustrate this with several clinical cases from our practice. Thank you very much for your attention, and let us begin. Conventional tympanometry measures the middle ear using only one probe tone, usually 226 Hz. It shows how compliance changes with ear canal pressure, so we get a two-dimensional tympanogram, pressure versus compliance. However, the middle ear does not work at only one frequency. Its mechanical behavior changes across a wide range of frequencies. Wideband admittance, or WBA, expands this idea. Instead of using a single tone, it measures how the middle ear responds to many frequencies at the same time. Because of this, we move from a simple 2D view to a 3D view that includes pressure, frequency, and admittance. This gives a more complete picture of middle ear function and can reveal information that conventional tympanometry may miss. To understand wideband tympanometry, we look at the resonance frequency. This is the point where mass and stiffness are in balance. If a condition adds mass, like middle ear fluid, the frequency goes down, below 700 Hz. If a condition increases stiffness, like atosclerosis, the frequency goes up, above 1200 Hz. This is why WBT is better than the traditional 226 Hz test. It can detect these small changes. To study wideband emittance in the clinic, we selected some common middle ear problems. Our goal is to see how these conditions change the sound behavior of the middle ear. These are problems we often see in daily practice. They include tympanic membrane perforation, stapes disarticulation, and stapes fixation, often linked to otosclerosis. We also include negative middle ear pressure, usually due to eustachian tube dysfunction, and middle ear fluid, often seen in otitis media with effusion. The aim of this presentation is to show how wideband absorbance works in real clinical cases, together with other hearing tests, and to see if all results match into one clear clinical picture. In the previous slide, I showed the middle ear problems we included. Now the question is, how can we use wideband tympanometry to tell them apart in clinical practice? This slide shows a simple decision tree. We start with the patient, and first we check the ear canal volume and the 226 Hz tympanogram. If the tympanogram is flat and the ear canal volume is large, this suggests a perforation or a ventilation tube. If the volume is normal, the next step is to look at the wideband absorbance. Each condition shows a different pattern. For example, middle ear fluid gives a general drop in absorbance, mainly at low frequencies. Negative middle ear pressure also affects low frequencies, but the pattern improves at peak pressure. Wideband measures can also help us tell apart stapes fixation and stapes disarticulation, because they change the middle ear mechanics in different ways. Finally, we confirm the diagnosis with other tests, such as OAS, acoustic reflexes, audiometry, or VEMPs. Now we move from the decision tree to clinical examples. I will show 5 cases. Each case represents one middle ear condition from the decision tree. The goal is to see how these conditions look in real patients and how we can use wideband tympanometry in practice. In each case, we will not look at WBA alone. We will compare it with tympanometry, acoustic reflexes, and audiometry to reach a clear diagnosis. Let's start with the first condition, tympanic membrane perforation. In this case, we see 2 tympanic membrane perforations. In the right ear, the perforation is central and epidermized. The left ear has an anterior perforation. There is no single WBA pattern for perforations. The curve depends on the size and the location of the hole. This changes the normal balance between mass and stiffness. In the left ear, we see lower absorbance at low frequencies and higher absorbance at high frequencies. A large hole reduces the normal stiffness of the membrane. Sound, especially high frequencies, can pass more easily through the defect. In the right ear, absorbance is slightly higher between 1 and 4 kHz. This irregular, wavy pattern is typical for perforations. The air in the hole acts like a new acoustic mass. It interacts with the volume of the middle ear and mastoid. This creates an imbalance and produces these irregular curves. When we compare with other tests, we find absent reflexes, no OAEs, and severe sensory neural hearing loss in both ears. So, the hearing loss is cochlear. The perforations only change the mechanical behaviour, and this appears as a pattern in WBA. Now we look at Stapes disarticulation, a type of ossicular chain problem. In this condition, the stapes loses its normal connection. The middle ear becomes too mobile. This causes a conductive hearing loss. In the next slide, we will see a clinical case and its wideband absorbance pattern. In this case, 226 Hz tympanometry shows high compliance in both ears. This means there is a strong loss of stiffness in the middle ear system. In wideband absorbance, we see a clear peak around 700 to 800 Hz. There is also high absorbance at low frequencies. This happens because the ossicular chain is no longer connected. The normal stiffness is lost. The balance between mass and stiffness is changed. The resonance frequency moves down. This creates a peak at low frequencies, where sound energy is trapped instead of going to the cochlea. However, the audiogram shows a conductive gap, with a Carhart notch at 2 kHz. This pattern usually suggests increased stiffness, like in otosclerosis, so we have a contradiction. WBA shows low stiffness, but the audiogram looks like high stiffness. This shows the value of WBA. It reveals the real problem. The ossicular chain is disconnected. This example shows why we must use all tests together to reach the correct diagnosis. Now we look at stapes fixation, the main mechanism in otosclerosis. In this condition, new bone fixes the stapes footplate. The middle ear becomes stiffer. This causes a conductive hearing loss. In the next slide, we will see a clinical case and its wideband absorbance pattern. In this patient, the findings strongly suggest otosclerosis, or stapes fixation. This fixation increases stiffness in the middle ear system. It changes the normal balance between mass and stiffness. Low frequencies depend on stiffness, so wideband absorbance is reduced at low frequencies. The increase in stiffness also moves the resonance frequency higher. The absorbance peak shifts to higher frequencies. The 226 Hz tympanogram looks normal, type A. The tympanic membrane still moves well, but the stiffness at the oval window blocks sound transfer. So, acoustic reflexes and OAEs are absent. Audiometry shows a conductive loss, with a Carhart notch at 2 kHz. When we combine all results, we see a clear pattern of high stiffness. Wideband absorbance shows this stiffness directly. This helps us diagnose otosclerosis, even when tympanometry looks normal. Now we look at negative middle ear pressure, usually caused by eustachian tube dysfunction. When the pressure is negative, the tympanic membrane is pulled inward. This increases stiffness in the middle ear. Sometimes it causes a mild conductive hearing loss. In the next slide, we will see a clinical case and its wideband absorbance pattern. Let's look at a clinical case with suspected fluid in one ear. Tympanometry shows negative pressure in both ears. The right ear is more affected, with -279 decipascals and a retracted tympanic membrane. Fluid adds mass and friction to the middle ear. Strong negative pressure also increases stiffness. This change in mass and stiffness reduces sound transmission. In the right ear, wideband absorbance is low across most frequencies. The system reflects sound instead of absorbing it. In the left ear, absorbance is normal. The balance between mass and stiffness is still preserved, despite mild negative pressure, -130 decipascal. When we compare with other tests, we see absent OAAs and an airbone gap only in the right ear. The left ear has normal hearing and present OAAs. These results show that wideband absorbance detects the global effect of fluid and stiffness. This confirms fluid in one ear. Now we look at middle ear fluid, also called otitis media with effusion. In this condition, fluid fills the middle ear space. The system becomes heavier and less efficient. This usually causes a conductive hearing loss. In the next slide, we will see a clinical case and its wideband absorbance pattern. In this case, all findings are consistent with otitis media with effusion, meaning fluid in the middle ear, linked to eustachian tube dysfunction. First, wideband absorbance is reduced across almost all frequencies. The curve is flat and low. This happens because the fluid reflects most of the sound. Second, tympanometry shows negative pressure and low compliance. This means poor ventilation and a very stiff middle ear, close to a type B pattern. Third, audiometry shows a moderate hearing loss with a clear conductive component. There is also a sensorineural component. Together, this gives a mixed hearing loss. Acoustic reflexes and OAs are absent, as expected. The middle ear problem blocks sound transmission. Otoscopy shows a retracted tympanic membrane. Myringotomy confirmed the presence of fluid. All results together indicate bilateral otitis media with effusion, on top of a previous sensorineural hearing loss. Let me finish with some key conclusions. First, wideband acoustic emittance gives a more complete view of middle ear mechanics than the 226 Hz test. Second, different middle ear problems show different WBA patterns. This helps in the differential diagnosis. Third, WBA is more useful when we interpret it with other hearing tests. Fourth, combining WBA with tympanometry, acoustic reflexes, OAEs, and audiometry improves diagnostic confidence. Finally, this combined approach helps us reach a clear and useful diagnosis of middle ear disorders. Thank you very much for your attention.